Good afternoon and welcome to the Chief Medical Officer for Scotland's annual report launch event. I'm Julie Aiken, a paediatric doctor and Scottish Clinical Leadership Fellow working within the Office of the Chief Medical Officer this year.
And I'm Savita Bittomuthunagam, a sexual and reproductive health doctor and a former Scottish Clinical Leadership Fellow. Julie and I are the chief editors of this year's CMO annual report, Recover, Restore and Renew. We're also your hosts for this launch event.
So over the next 2 hours, our speakers will provide an overview of this year's annual report and the salient issues raised. We also have the privilege of hearing from our keynote speaker, Professor Victor Montori. We hope this session will allow time for reflection on our experiences of the last year and consider how we will move forward.
We're delighted that so many of you have been able to join us this afternoon for what we hope will be a thought-provoking event. So far, it looks like we have over 690 attendees. We will be tweeting live from the event, so if you would like to tweet about your experience, or if there are any messages that really resonate with you, please use our hashtag Realistic Medicine and join the conversation.
Let's kick off the session by hearing from our Chief Medical Officer, Dr. Gregor Smith. Gregor is a general practitioner, former Director of Primary Care in NHS Lanarkshire, and is an Honorary Clinical Associate Professor at the University of Glasgow. He was appointed as Chief Medical Officer for Scotland during the coronavirus pandemic and has been front and centre in our collective efforts to tackle the virus from the very beginning. Dr. Gregor Smith.
Thanks, Julie. Welcome everybody, and I'm really grateful for everyone taking such an interest in the launch of my first annual CMO report. It's a time for reflection, I think, for all of us as we look back in the last 12 months and the events of what have happened during the course of this pandemic. It's different for all of us, of course, but all of us will have had an experience that I'm sure has been pretty much life-changing. So this represents a point in time, I think, where we can come together, where we can take breath, we can understand a little bit of the changes that we've made within the system, how they have impacted both on us personally, but more importantly for our the people that we provide care to, and perhaps even an opportunity to recommit to how we use realistic medicine as a tool and an approach across Scotland that makes sure that the care that we provide for people is fair, is just and is equitable. The last 12 months have been a particularly trying time for myself. I don't think 12 months ago I would have expected that I'd be sitting here launching my first report. And in fact, when you look back on the first report of realistic medicine that we launched 5 years ago, I suspect that there weren't many of us involved in this webinar today who would have thought that we'd be experiencing a pandemic of the scale that we've experienced and the changes that we've gone through, both in terms of the way that we deliver services, but also as a society within that 5-year period. It's important that we do take time to understand exactly how that's impacted upon all of us and impacted upon both the care that we provide and the outcomes that our population has experienced during that time. This report allows us the start of that opportunity to learn and to further develop some of the thinking that we have been compelled to undertake during the course of the last 12 months. There's been massive changes in the way that we have delivered care and in people's experience of care over that time. The report begins to touch upon some of those aspects, and today we'll hear from some of the contributors who have authored some of the chapters of the report to hear a little bit about their perspective and what the last 12 months have meant for them as well. What I want to do now is just very briefly just touch upon the different aspects of my report and why we have framed it in this way. I felt that it was very important, first of all, to start by acknowledging the health of the nation. And in that chapter, what we begin to explore is some of the trends, particularly in life expectancy, that Scotland was experiencing even before our first signs of the pandemic were arising this time last year. This is important because what that data begins to tell us is that even before the pandemic struck, we were starting to see changes in life expectancy in Scotland that we need to much better understand so that we can implement policies and interventions which begin to mitigate some of the effects. Because what we were seeing with that data was that life expectancy in Scotland was beginning to stall, and in fact, in some instances, in some age groups, and particularly in some demographics, we were starting to see a reversal of that life expectancy, the continual improvement in life expectancy that we've seen for many, many decades. We'll hear from Jeremy McCartney today, who authored that chapter, and he'll begin to explore some of the concepts which he introduces there. During the response to the pandemic, we've been compelled to work in a different way across health and social care. One of the things that I've heard very strongly from people is that realistic medicine has been a very important aspect of the way that they've delivered care in that time. And in the second chapter of the report, we begin to explore some of the interventions, some of the initiatives that have been undertaken across Scotland to use realistic medicine in practice to try to shape our response so that we ensure that we were still providing that really important person-centred care to people across Scotland in the most difficult of circumstances. We'll then go on to explore the impact of health inequalities in Scotland. Now, everybody involved in this call will be aware that health inequalities have been a feature of the Scottish health and care landscape for many, many years. But the pandemic, as many pandemics have done beforehand, have amplified some of the impacts that it has on some of our population, so that those who are perhaps more likely to experience disadvantage in our society have actually been hit disproportionately hard by the impacts of the pandemic, not only in their health outcomes, but also in the social inequalities that they face in our response as well. And in this chapter, I guess what we begin to do is to explore how can we recommit to, with some urgency, to reducing those health inequalities that exist across our society. As a GP in Lark Hall, I saw those health inequalities very starkly every day, and my own family has experienced some of the impacts of those health inequalities as well. And I think if there's anything that we can do as a group of health and social care workers for the coming years ahead, it's for all of us to recommit and explore what our own contribution is to tackling those health inequalities. I'm very certain in my mind that health and social care can't do that alone. It's the way that we work with different sectors of society, whether that be different aspects of public sector, whether it be third sector or even the private sector, but working together to try to reduce those inequalities and build a much fairer society as we build back better. In the second last chapter, the penultimate chapter of the report, we explore the quite extraordinary impact that the pandemic has had on our workforce. And it's something that I'm particularly conscious of. This has been the hardest year of my career, beyond a shadow of a doubt. And it's only through the support of those around me, by working in what has been an absolutely wonderful team, that we've been able to navigate our way through it to this point. And I suspect that many people's experience of the last 12 months has been very similar. That wonderful, supportive and sometimes gallows humour that comes through amongst people when they're working under particularly stressful circumstances has been something which has sustained me quite significantly over the last 12 months. But I'm conscious of the impact that this has had on many aspects of our workforce. Some of the data that I've seen over time, particularly in relation to the impact and emotional trauma that parts of our workforce have experienced under quite extreme circumstances, has been frankly heartbreaking. Again, I would ask us all to commit to making sure that we do all that we can to support our colleagues during these difficult times, and that we ensure that the infrastructure is there and accessible for everyone who needs it, should they need help. And finally, in our last chapter, something we have toyed with the idea of for some time within realistic medicine, and this is the first time that we've explored it more fully, is the impact that health and social care services have on the greener and climate action, and what our contribution might be in trying to make our health and social care services more sustainable, not just in terms of the resources that we use and on a day-to-day basis, but how we contribute to that wider aspect of climate action. Later on this year, Glasgow will be the host city for the world's largest climate action conference, COP26, and health will feature very, very strongly as part of the work stream for that, so that as a global health community, we can perhaps begin to explore the action that we can take contributory to reducing the impact on our global resources as well. I mentioned the importance of teams in my introduction, and I want to dwell on that just for a little second before we move on. Many of you will work in teams in everyday life. As a GP, I worked in an extended practice team that involved not just people in my immediate practice, but the teams from across community services who helped us with our patients every day. The camaraderie that we had in that environment was incredibly important for dealing with some of the really stressful situations that we found ourselves in. And it's been exactly the same for me over the last 12 months. The team that I've worked with here in St Andrew's House in Edinburgh, my Deputy Chief Medical Officers, my Chief Science Officer, my Chief Pharmaceutical Officer, and all the extended clinicians and officials that I've worked with on a daily basis. We've all worked very closely together in a way that is mutually supportive. I hope that your experience of the last 12 months has been the same. But one of the things that I think is really important as we begin to negotiate our way not only through the pandemic but back out of the pandemic is how we preserve the best of those relationships for the future, the civility and the support that is absolutely necessary and should underpin everything that we do as a professional. And my last request for all of you is to commit to working with others and working with those that you provide care in a careful and kind way, so that we understand exactly what it feels like to walk in their shoes, that we try to explore with great care what's important to them, and that we make sure that the aspects of realistic medicine, which we all hold really dear and important to us, are at the forefront of the way that we provide care to people across Scotland every day. Thank you to everybody who's been involved in the preparation of this report. I want to single out Julie and Savita for all the work they've done as co-editors of this report. I hope that they're as proud of the product that they are publishing today as I am. It is everything I could have wished for in my first report. The support that they've had from the Realistic Medicine team has been fabulous as always. So thank you to Craig, to Jennifer and all the team for everything that you have contributed to this. And to our authors of the various chapters who you're about to hear from, my deep, deep gratitude for what you have contributed. And we'll explore some of these concepts in more detail over the course of the rest of this webinar. So thank you, everybody. And I'll hand back to Julie now, who's going to take us through the next steps.
Thank you very much, Gregor, for your reflections of the past year. We'll now provide you with an overview of the key themes discussed in this year's CMO's annual report. So I'd like to extend a very warm welcome to our panel, who will introduce the chapters. There will be an opportunity to ask questions, so please pop them within the question box that some of you have already started doing. But please note, because we have now over 800 attendees, that we might not be able to get around all of them. So first up, we have Dr. Jerry McCartney. Jerry, over to you.
Thank you, Savita. And my name is Jerry McCartney. I'm a consultant in public health at Public Health Scotland, and I'm delighted to present the first chapter of Gregor Smith's first annual report, which is about the health of the nation. In this report, or in this chapter, as Gregor's outlined, we detail some of the big public health challenges that pre-existed even the pandemic. Gregor's mentioned that the mortality trends in Scotland had actually been stalled for quite some time prior to the pandemic hitting. From 2012 onwards, mortality and life expectancy had barely improved at all across Scotland, in common with many other parts of the UK and Western Europe. Indeed, that average trend hides some of the even worse trends for our more deprived communities. The 40% most deprived areas in Scotland actually saw declining trends in life expectancy over that time period. We're increasingly clear that the causes of this are largely economic. We know that we've had a decade of austerity. We know that people's work experiences have changed markedly with a rise in precarious work and short hours and 0 hours contracts. We also know that there's been quite profound changes to the social security system over this time period, with an increase in the use of conditionality and a decline in the real-term values of many benefits. That's meant that for the poorest 10% of the population, they've actually seen a real terms cut in their incomes of 8%. Of course, as Gregor Smith also mentioned, the pandemic has not been kind to our most deprived communities either. The direct impacts of COVID morbidity and mortality have disproportionately affected our most deprived communities, and the indirect impacts of the control measures that we've had to introduce to control the virus have also had particularly bad impacts on people's incomes, on education, on social isolation, and also on people's use of health services. But all of this presents us with an opportunity. As we come out of the pandemic and as we look to build back fairer, as Michael Marmot has said, we've got the opportunity to address some of these health inequalities that have blighted Scotland for so long, and we've also got the chance to build back more sustainably and make our contribution to the climate crisis. I'd like to hand over now to our Chief Nursing Officer, Amanda Croft, to introduce the next chapter.
Hello everybody, I'm Amanda Croft, I'm the Chief Nursing Officer. Now, I've only been in post a few weeks, so I'm really pleased to be with you today to support the launch of Gregor's annual report. Within the report, I introduce the personalised care chapter, and this reiterates the continued importance of delivering personalised care through shared decision-making, particularly during the pandemic. It highlights the innovations and transformations that we've seen across health and social care that have enabled the delivery of person-centred care throughout the past year. We will all recognise that our ability to provide such personalised care has no doubt been challenged by COVID-19. However, keeping people at the heart of their care during this time is more important than ever. This chapter showcases and celebrates how our staff have risen to the challenge and continue to provide person-centred care despite the immense challenges that has been brought about by this pandemic. For this chapter and our considerations, we're keen to think about how can we change our behaviours and practice to deliver more personalised care that best meets our needs and wishes of the people that we care for. How can we improve our collaboration with colleagues to better coordinate care, especially to those living with complex conditions? And how can we utilise the learning from such programmes such as the Scottish Access Collaborative and the Modernising Patient Pathway programme to help streamline patient pathways to reduce waiting times and ensure that people receive the right care when they need it? And lastly, how can we reduce harm and waste by considering whether a treatment or an investigation is going to be of value to the people that we care for? And as we know, that's at the very heart of realistic medicine. I'm now going to hand over to Diane Stockton. Thank you.
Thank you very much. Thank you. So I'm Diane Stockton. I'm a consultant in public health at Public Health Scotland, and I'm going to just introduce the Health Inequalities chapter. This chapter draws attention to the widening inequalities that we've seen in Scotland, that, as has been discussed with Jerry McCartney in the previous chapter, and it covers why that cannot be resolved by healthcare alone. The highlight of the chapters are explanations of the Deep End GP programme and the welfare advice and health partnerships. It looks at the wider economic and fiscal policies that we have to tackle inequalities, It describes work on the period poverty bill and the race inequalities action plan. And there are also interesting case studies of inclusion health and some of the ways that we're trying to address tackling drug-related deaths. We're really interested in that topic at the moment because obviously the pandemic has shone a glaring spotlight on the health inequalities that exist across our society. And so tackling inequalities is a top priority. And while health inequalities are primarily driven by the wider socioeconomic determinants of health, we all have a responsibility in our day-to-day work and our day-to-day lives to do what we can to address them. So the main points in the chapter are for you to consider some of the key take-home messages. So what can you do to tackle health inequalities in your everyday clinical practice? And what can we all do to help ensure more equitable access to the services we provide? How can we help and support the people we care for to access the socioeconomic help they need beyond healthcare? And what can we do to make sure that the people we care for receive all the information that they need in the way that they understand? Thank you. I'll now pass over to Cameron Herbert.
Hello, my name's Cameron Herbert. I am a Scottish Clinical Leadership Fellow and also a Paediatrics Registrar, and I contributed to the Sustainability of the Workforce chapter of the Chief Medical Officer's report. So going into 2020, over a year ago, we know that we had a health and social care workforce that was under really significant pressure, and there were many examples of this. In NHS Scotland, nursing vacancies had reached an all-time high. 1 in 4 doctors in training were reporting a really high degree of feeling burnt out, and nearly 40% of general practitioners are reporting feeling overwhelmed by an excessive workload. So this was the backdrop to the events we know that happened in the last year of the COVID-19 pandemic. So we start this chapter looking at these pressures, and we look at the results of the iMatter survey that was taken in the latter half of the year and focus in on some of these pressures and stresses that were affecting the workforce more than any other time than we've seen before. Through these challenges, though, we highlight some of the really many excellent examples of caring for one another in our workforce, and we highlight many of the good wellbeing initiatives that were taken locally through some of our case reports, and we look at some of the national wellbeing initiatives that were put in place, like the National Wellbeing Hub and Wellbeing Champions Network. We then take a look at the really incredible response across health and social care around responding to this rapid change and adapting, such as telehealth and the rollout of remote consultation software. But we know that no amount of wellbeing initiatives are really going to solve all the difficulties that we face in health and social care. So we dive into, in the chapter, how we need to recover, restore and renew our workforce to ensure that working in health and social care in Scotland really is sustainable, that we can practice good realistic medicine. We look at the importance of having connected teams, in particular compassionate teams led by compassionate leaders, and we know the evidence shows that being in a connected, supportive team leads to a less stressed workforce, but also better quality of care. And key to this is having a diversity of people and voices in the room leading us, and this leads to better innovation and better realistic medicine. So I hope this chapter does some justice to all the extreme hard work that's taken place over the last year from individuals in health and social care and in the system, but that we also sound a note of hope about how we can rebuild and restore from where we are to build a really sustainable workforce. So please have a look at our recommendations in the chapter about how we can show self-compassion and compassion to our teams, and if we're in a leadership position, how we build a diverse leadership. And I'll now hand over to Emma Watson. Thank you.
Thanks, Cameron. My name's Emma Watson and I'm the Deputy Medical Director in NHS Highland. And it was an absolute privilege to be invited to collate the Green and Sustainable Healthcare chapter. And like Gregor, I need to absolutely acknowledge the work that Savita has done on the CMO report. So Scotland, some of you may not know, has the most ambitious climate legislation in the world. And as a country, we are firmly committed to reducing carbon emissions by 3/4 by the end of this very decade, and by being net zero by 2045, ending Scotland's contribution to climate change in a generation. That is remarkable, and we absolutely have to contribute to that as healthcare providers. As Gregor said, 2021 is the year when Scotland will host the UN Climate Summit. It's absolutely right and proper that we focus the minds and efforts of all clinicians and not just the interested few anymore. This chapter will highlight for you the impact of climate change on health. It will illustrate the role of NHS Scotland as a significant contributor to greenhouse emissions. NHS Scotland is one of the biggest road users in Scotland, and we need to be thoughtful about that. In the chapter, we will draw your attention to the NHS Scotland approaches to tackling climate change, introduce you to the NHS Climate Change and Sustainability Strategy, and revisit the commitments made by the Chief Executive of NHS Scotland to become net zero. We'll look at the environmental impacts of the response to COVID-19 and potentially what is possible. There's some fantastic case studies from across health and social care showcasing approaches to make healthcare greener. We hope that during your reading of this chapter, you'll see the importance of fostering a culture of stewardship of our healthcare resources and the absolute need to understand and mitigate against the environmental impacts of healthcare delivery. Why now? Well, we've said already about the ambitions of NHS Scotland to reduce our carbon emissions by the end of the decade, but also the global response to the COVID-19 pandemic and the decline in emissions in the early part of 2020 just show the reams of possibility in terms of changing human behaviour, our behaviour, to have positive impacts on the environment. And we need to build on those climate positive behaviours and build back greener, and a full credit to Jerry for that term. So what would I like you to take home from reading this chapter? Consider what you can do within your sphere of influence to practice greener and more sustainable healthcare. Perhaps you could lead a greener healthcare team. Look at the system where you work, collaborate with colleagues to reduce harm and waste. And how can you influence and empower your patients to practice climate positive behaviours? You know, that very supportive encouragement to walk, not drive. But most of all, I hope you'll read the examples as a catalyst for change and an inspiration to do things differently. We need to break our habits. And let's go forward knowing that realistic medicine can be greener and more sustainable and improve the healthcare that we deliver. Thank you. I'm going to hand back to Savita.
Excellent, thank you. We hope this brief taster will generate some interest around the key themes in the report. Now we have the opportunity to ask the panel and our Chief Medical Officer for Scotland questions around the significant issues discussed within the report. So I'd like to welcome all of the panel back. Slowly coming in, perfect. Great, okay. Perfect, so we have quite a few questions coming through and we'll try and get round all of you. But there was a question that came in for Gregor. That is, someone had said that they think teams are extremely important and the linking across services even more so. So they're asking, do you have any direction on how we further improve communication and join up working between secondary services and GPs?
It's a fabulous question, and you know, even before the pandemic arose, there were moves across Scotland to try and promote that sense of narrowing the gap that could exist between some parts of the system. We've often spoke in the past about minding the gap, the artificial part of the system that lies between secondary care and primary care. Well, you know, patients don't understand that. Patients only see the care that they get. They don't understand that there's such a thing as different sectors. And one of the things which I would certainly commend and promote would be that some of the close working practices that have been put in place in many areas of the country as clinicians from that hospital sector, clinicians from the community sector come together to discuss common issues that they have and common approaches that they need to undertake to make the care better within the systems. I also think there's been a blurring of some of those working practices as well. We've seen wonderful initiatives across the country. Things like, I would pick out Professor Graham Ellis and the teams that he has helped to promote across the country in terms of the hospital at home services as different ways of traditional community-based services working much more closely, much more collaboratively and in extended teams with what in the past have been hospital-based services. I would love to see much more of that, because, as I say, from a patient's perspective, in terms of who provides me with the care, all I want to know is am I getting careful, kind care from an appropriate person? Whether they're housed in a GP practice or in a hospital or in one of the local community health care centres, doesn't really matter to me. It's the quality of the care, and that quality of care, I think, very much is made much better when we work together using the blended skills that we have across all those different professions involved in the care, and that we make sure that the communication between both those professionals and the people that receive care are absolutely optimised, with at all times the perspective of the patient guiding those teams as to what their preferences are in terms of how they receive the care as well.
Fantastic. And we do have one more for you, Gregor, and then we'll ask some of the other panellists. So what do you think our biggest health gain has been due to COVID?
Wow, what a question. I think at this point in time it's difficult to think about health gains in any sense in terms of outcomes, because I think our experience of the pandemic has been one which has been really quite traumatic for many families and much of the workforce across the country. But if we're looking at what the health system has gained as a consequence of the way that we've been compelled to work differently, I think that there is lots of learning that we can take from our response that we would want to really consolidate, go further with, and make sure that it was becoming part of our everyday experience of how we provide and receive care across Scotland. So we pick out examples such as NHS Near Me, the use of digital technology to make it much easier for people to access care in a way that is easier for them, as a particular example. I spoke at lunchtime in our lunchtime COVID press conference about some of the wonderful gains that we've made in understanding pathogen behaviour through genomic sequencing. And again, I think that's something which we've now consolidated and which we can use in the future in ways which will benefit people further again. It's examining these aspects of care, making sure that they still hold the patient at the centre and the focus, and reduce those barriers which have artificially been put there in the past, both between professions and between professions and people who receive care. Anything that we can do to reduce those barriers to make it a much more equitable relationship, and I think there's many examples of that, is something which we would want to preserve and consolidate around for the future.
Definitely. And so I'll move on to Jerry next. So Jerry, what would you say is the biggest challenge facing our population health?
Thanks, Julie. So clearly the most acute challenge at the moment is the COVID pandemic, and coming through that in a way in which we managed to mitigate as many of these adverse consequences for people's health in the short, medium and long term is clearly right up there. But as we've described in the report, we've got a long history of population health problems in Scotland. So health inequalities have been increasing in Scotland for 40 years. Our life expectancy trends stopped improving around about 2012. And we've got, a crisis around mental well-being as well. And we need to think about not just mortality trends, but also people's well-being and their general health. However, the causes of these are common. So we know that what's driving the stalled mortality trends are the same things that are driving the health inequality trends. I think we've all understood much better, and I think the public understand much better as a result of the COVID pandemic, how important inequalities are. And I sense that there's much more appetite for really taking serious action to narrow these inequalities in the future, and I commend Gregor for highlighting that in his first report, and hopefully that will galvanise coherent action across all of Scotland to make a real difference in that into the future.
Grant, and that brings me on to Diane nicely. So the inequalities in our society have become more pronounced, as Jerry says, during the pandemic. How, as professionals in health and care, can we help to address these?
Thanks. So, I mean, obviously, a lot of the inequalities that we have are due to really fundamental factors, and the economy is going to be such a big element of that. But on the health and social care side, what we really need to do is shift the focus from treating to more around prevention. So we already do a lot of that, but we need to do that more. And especially when you think about coming out of the pandemic, we already had inequalities in what we think of as behaviours. So, you know, obesity, alcohol use, smoking, drug problems. There were already big inequalities before the pandemic started. Now they're going to be exacerbated by the pandemic. So, you know, as a workforce, you know, what can we do to try and reduce those inequalities going forward? You know, how can we work with people to look at those and try and make sure that we reduce them where we can and have equitable access. There's also all the work around the inverse care law. So we know that people that need more healthcare, you know, often are not getting as much healthcare because they don't attend healthcare services unless they really, you know, once they're at the end where for that kind of early intervention stage. So it's how do we work with people more who've got really complex health and social problems. And there's great examples of that from for example, the Deep End, you know, the GP Deep End work, where they really do amazing work with very deprived populations, with longer consultations and working with them in a different way and really trying to involve them in decision making. People that have got quite complex lives, trying to really involve them more in decision making. So I think there's some really good pointers in the report to the areas where we could really make a difference as healthcare professionals.
Rob, that's great, thank you. And a question for Amanda now. So what do you think is the most important thing that you've personally learned from the pandemic?
Thank you, Julie. Gosh, there's lots, isn't there? At the start of the pandemic, the job I was in was a chief executive in a health board in the Northeast, NHS Grampian. And I think that there's probably three things I would highlight that I learnt from the start of the pandemic and working through it. And one is, and it touches on what Gregor was speaking about around teams. I can't emphasise enough the importance of the teamwork during the start of the pandemic and as we worked through it. The second thing would be communication. You just cannot do enough of it, and that's not just to the staff, the patients, the relatives, but the public as well. Everybody was scared, were anxious, and that communication is really key. And I think one of the things that we learnt as a team was that you needed to communicate in different ways. So we did lots of videos, did lots of podcasts, we communicated in writing, we did as much face-to-face, given the circumstances that we could and that I could. But I think one of the biggest personal things that I learned was the saying it's okay to be not okay. Even as a chief exec, as a professional, we were all anxious. It was a scary time, both personally and from a work point of view. So I think that message that it's okay not to be okay was a big learning point for me. Thank you.
Yeah, and that's so important, that message, and I think it will become even more important as we move forward. Great, and I'll move on to Cameron now. So a large number of frontline staff are feeling burnt out at the moment as a result of the pandemic. So how do we feel we can support and sustain our workforce as we recover our services?
Thanks, Julie. Yeah, this is a really complex problem about how we rebuild our services in health and social care after a pandemic while making sure our workforce doesn't end up burnt out in the process. And we talk about this in the chapter, and one of the things we reference is a framework that we find helpful for looking at this. And that comes out of some of the work from Professor Michael West and Dame Denise Koya in the report they did into the mental health and wellbeing of doctors, but also the recommendations equally apply to all professional groups across health and social care. And the framework they use is looking at autonomy, belonging, and competence. So autonomy is the need to have some control over your work life, acting consistently with your values. Belonging is what many of the panel have talked about, is feeling connected to your team, cared for by your colleagues, being valued and respected, and having really effective team working with compassionate leaders. And lastly, that piece of competence, which is just being able to deliver effective and high quality care. And part of this is really tackling the problem of really chronic excessive workload, which we see sometimes in our health and social care, and is one of the biggest predictors of stress. So we think that's a useful framework to think about when we're rebuilding our services, but it's a really difficult problem and one that's going to take a lot of thought. Thank you.
Definitely, and I might just go back to Gregor in terms of sort of wellbeing, because I know there's a lot of work going on about that at the moment. Just if you want to touch on that, Gregor.
Yeah, it's something which clearly there has to be a lot of interest in, and it's one of the, I think it's been one of the most striking features of our collective response to the pandemic is how the experience across the workforce within health and social care has been slightly different, but has all been much more intense than perhaps they've been used to. I've seen some data and listened to some accounts of what the working environment has been like, which yeah, been really difficult to listen to. I have to say, to hear people's experience of how they've dealt with both the intensity of the care that they've been expected to provide, but also some of their own fears at the same time that they've had when they've been delivering that care. We've got to listen to that. And so throughout the pandemic, what we've tried to do is strengthen the infrastructure that we've had through the development of, first of all, the wellbeing hub, and then various lines that people can access so that they can be guided towards people who can help to support them better. And I think that there is a need to make sure that as we navigate our way through and beyond the pandemic, as we see it just now, is that we preserve, we consolidate, and we make sure that we recognise that this isn't just a straight equation, that as case numbers begin to drop across the country, we can simply flick a switch and expect staff to pick up where they left off. That's completely the wrong approach. That's why it's so important that we take this period to make sure that we, first of all, understand what it feels like to have worked through the last 12 months, to make sure that we've got the infrastructure in place to support people, but we allow people that opportunity to recover, because one of the biggest challenges that we face over the coming months is how we balance the dual needs of continuing to provide care for people with COVID disease, which there will be for some time yet, with the unmet need that exists across the society, and as Jerry and others have spoken about, is disproportionately felt by some parts of society, whilst at the same time making sure that we don't place too much expectation on our health and social care staff at a time when they too need kind of an opportunity to recover from their experience as well. That's going to be a fine line to walk over these coming months. But Amanda, myself, Jason, others will be watching this very, very carefully to make sure that as we begin to open up services again, we do so in a way that tries to allow that opportunity for people to have that moment of recovery, that pause for breath, where it's possible to do that, so that they can, as I say, people have often said, kind of build back in a way where we deliver care in a way, because believe me, the threat is there that if we don't do that at this point in time, if we don't understand that, and if we don't take action to address that, the care that we provide in the future and our ability to be able to sustainably provide that care as well with a workforce who remain well is going to be compromised. So this is investing both in our workforce for the future, but also in the quality of care that we provide for the future as well. And it's something that I know myself and Amanda feel very strongly about. Definitely.
And I think the other crisis that we have to address, I suppose, is the climate crisis. So I shall come to Emma now. A question's come through saying, what do you see the impact of COVID-19 having on sustainability goals? For example, there's been an increased use of single plastic PPE during the pandemic. And what can we do as professionals in health and care to try and tackle the climate crisis?
Great, Julie, those are fantastic questions, and I'll maybe take them in reverse order, if that's okay. So I think that the second part of your question was, what is it that we can do as professionals to really actively get involved in delivering more sustainable healthcare? And I think the very first thing we can do is be curious about it. And really challenge ourselves at the end of every day or at the end of every week. What could we have done differently to reduce the carbon impact of what we've just done this week? Before COVID, when I think it was the first or second realistic medicine report came out, there was a striking statistic that there were over 2 million outpatient appointments in Scotland. And think of the car usage there. And our response was to build more car parks, rather than to think really differently about how we delivered. And COVID-19 has really forced us to think differently, in part to protect ourselves as healthcare workers, but mainly to protect our people. And actually, the use of near me, the reduction in returns, the much more person-centred approach to delivering care has also been climate friendly. Let's not shy away from that. Let's look with the lens of green and sustainable healthcare around every initiative that we bring to bear. The other thing as professionals is that we're people and we're role models, and people watch what we do. And we should really be thoughtful about our car use. We should be thoughtful about walking more, even down to recycling. And it sounds glib, but in hospitals, over a third, and in some places 50% of the clinical waste is actually recyclable domestic waste. This doesn't take much effort. It's super easy to do, and let's start getting active and gently reminding each other, we don't have long to make a significant difference for generations to come, and we are really rapidly losing the opportunity. Single-use plastics, I've kept that one to the last because it's tricky, isn't it? Mm-hmm. And it's really tricky, because we've got to balance our infection control risk and as Gregor said, our knowledge about pathogen transmission with the risk of damaging the planet even further. So let's think about, let's use single use when only single use will do. Let's be really inquisitive about reusable things. Let's can we reuse certain items of PPE if they've been properly washed and laundered? Let's but balanced with the environmental impact of laundry. The whole thing needs to be taken apart, and we need to be really, really thoughtful and deliberate about everything that we do going forward. I absolutely don't want to put people at risk, whether they be our staff or our patients, but we need to look at the big picture and do something significantly different. It's a great opportunity for innovation. It's a great opportunity to enable people to come forward with something really positive as an outcome of PPE in the face of the pandemic. But I don't know that I have the answer clearly at the moment. Thank you.
No, that was a fantastic answer, I would say, because it's a very difficult subject. And I suppose, as you say, it is really just about thinking about these things now and addressing them and seeing what we can do as we move forward. So that was a really interesting discussion. I hope you all enjoyed it. I thank you for your reflections, and I'm sure that the points we've raised will generate further discussions within our health and care communities. So I'll hand back to Savita now.
Thank you, Julie. And now I'm delighted to introduce our keynote speaker, Professor Victor Montori. Victor is an endocrinologist and professor of medicine at the Mayo Clinic in America. He's the author of more than 500 peer-reviewed publications and is one of the most cited clinical researchers in the world. He is the principal investigator of the Knowledge and Evaluation Research Unit at the Mayo Clinic and is a recognized expert in evidence-based medicine and shared decision-making. In 2016, Victor founded the Patient Revolution, a non-profit organization dedicated to advancing careful and kind patient care for all. It's an honor indeed to have him join us today. Professor Montori, over to you.
Thank you very much, and thanks everyone for great work on a report that I've enjoyed reading, and I've reviewed previous ones and resonated with realistic medicine and the work that you're doing, which is an inspiration, I think, for the rest of the world. This slide shows my email address as well as my Twitter handle, and I would like to invite everyone to continue the conversation with me if something I say resonates with you or deserves further discussion, in addition to the time that we'll have for questions at the end. I have no financial disclosures to offer here. I work at a research unit at the Mayo Clinic in Minnesota in the United States. And one of the things that we do in this unit is we conduct research without any funding from any for-profit entity. A few years back, I published this book, but all the proceeds go to the Patient Revolution Organization. Some of the ideas described here are in this book. And although I chair the board for the Patient Revolution, I derive no income from the book or from the organization. When we talk about care, we often find ourselves feeling that this word needs adjectives. And so we offer sick care or health care or patient-centered care or evidence-based care or high-value care. And then our attention goes to those adjectives. But care is substantive. Care is the center of what we do, and care is what I'm going to be discussing today. Care is a practice. Care is a disposition. And I'd like to invite you to spend a few seconds observing this picture, watching this picture carefully, looking at the participants in this picture, looking at the markings on their skins, looking at their hair, at their eyes, looking at their hands, looking at their lips. Care as a practice and a disposition. I want to pause for a second to just reminded by this picture, to just reflect for a second on those we have lost to COVID, both families and friends as well as colleagues, and to renew our commitment of those of us who are surviving this to make sure that we take through the portal that COVID has opened the best of what we have now into a new world. And the key point of my presentation is that this new world has to be more caring than the one that we've started with. So what is this practice and this disposition? Well, it starts by noticing. It starts by having the presence of mind and the attention to look at someone or look at a situation of someone in high definition and realize that that situation requires response. And care requires being responsible, realizing that there's a possibility to meet the needs of someone else and deciding how we would do that. And then the work of caregiving, work with the patient or the person needing our care in a competent way, in a compassionate way, and then receiving that gift, that feedback of the care receiver who is able to tell us whether our response was pertinent, whether it was adequate, and whether it was desirable. And care, of course, extends beyond the caring of the other to the caring of the self, the caring of our communities, and as we have heard, the caring of our environment. And we need a world that is more caring than the one that we have. At a macro level, it reminds us of what healthcare is supposed to do. On the one hand, notice by assessing the situation, the problematic situation of the patient, and using the best available research evidence to organize its systems, its people, its information, its technologies to respond to that situation, to notice and respond, to care. But also, we must learn, we must evaluate whether that response was in fact adequate, effective, and desirable, and produce evidence that comes from that evaluation that we can use to adapt our response. Healthcare has to learn. We must care and we must learn. Notice that when we reflect on care, the icon that is used is hands one on top of the other. And that reminds us that care is often taking place in a situation where the caregiver is in a position of power, is in a position of in superior position to the care receiver, who is actually in a deficit situation. And so it is important that when we notice a problem and decide to respond, that we approach this only with one intention, and that is the intention to advance that problematic situation, with the intention to care. And in that process, we will develop a relationship, particularly with our patients with chronic conditions, where in that relationship, we will endure. Particularly if we experience adverse consequences from our care, this relationship and the strength of this relationship is where we would come back and regroup and try again. Unfortunately, in many health systems, that is not possible. Why? Because we cannot notice if the patient is seen too fast, too quickly, if they're seen as a test result or a statistic, or if they're seen merely as their representation in the medical record, if the patient is a blur. We won't be able to care if what we do is basically apply what the research evidence says we should do, without recognizing the particular situation of each person, following guidelines that constitute care for people like this patient, like Maria Luisa, rather than care for and about Maria Luisa. It is not the job to care for people like her. The job is to care for her. And so the care becomes generic. But also in responding to this situation, we give patients a lot of work. We ask patients to do a lot of waiting for our care, and we overwhelm their personal agendas with demands for personal responsibility for completion of medical errands. Our care is burdensome. And when patients cannot fulfill our expectations for what they are to be doing for themselves, we label them, oftentimes using cruel labels like non-compliance. We can be cruel. So instead of this picture of care, what we sometimes are able to do is to produce an industrial version of this, in which patients are aware that care is generic and burdensome and cruel. What is the effect of that? What is the effect of a healthcare without care? And the effect is unsustainable. On the one hand, many of the interactions are focused on documentation. In the United States, estimates indicate that when patients and clinicians are together, 40% of the time is spent attending to the needs of the computer. 40% of our patients with chronic conditions report that the workload transferred to them represents an unsustainable burden. And 40% of our clinicians are reporting now that they're at a loss, that they have symptoms of loss of empathy and depersonalization, that they are burned out. Healthcare without care is unsustainable. So we need to do better. How can we advance care? One initial step is to promote unhurried conversations. An unhurried conversation will allow us to determine what is the situation of the patient in high definition, in its biology and its biography, in its physiology and its sociology. That will allow us to notice. And it will allow us with the patients to co-create a sensible response, to a sensible resolution to their problems that reflects their situation, and also the best available evidence and their values and preferences. This notion of an unhurried conversation starts by recognizing that we need a space for care that is free of frictions and distractions. This is the cathedral as sculpted by Rodin. And to produce this image, this sculpture, Rodin is representing two hands, one of each person, coming together, almost touching, and creating a space within it. He called this the cathedral. In order to create that space, that sacred space between these two people, he had to remove all the rock that was between these two hands. And similarly, the task for care is to create the space for care to take place free of interruptions, free of frictions and disruptions. Therefore, measuring and achieving unhurried conversations becomes an interesting measure of the extent to which a healthcare system has been able to move away from industrial healthcare towards care. Because it is complex to achieve unhurried conversation, it requires a commitment of people to participate, in itself dependent on their prior experience, for how worthy it's been for them to participate, to how recognized and heard they've been in terms of their experience and expertise. And I'm not just referring to the clinicians, but also to patients who live with chronic conditions. But also unhurried conversations require that a certain rhythm, a certain tempo of care is established. This is similar to when people are going to dance and they recognize the song, but the song is played just simply too fast. And so, therefore, it makes it impossible to dance to it. Care is like that. Care requires a particular rhythm, a particular tempo. And when we organize healthcare, we must make sure that our structures, our teams, our policies, our information is supportive of that. It's not just a matter of giving enough time for the conversation to take place, but it's also important that we remove barriers, that we enable facilitators, that we prioritize and eliminate distractors. And in that unhurried conversation, patients and clinicians can notice and figure out what is the situation that really requires action, and respond by figuring out, by diagnosing what response the most intellectual, emotional, and practical sense for the care of this patient. And there are some things we can do to achieve this. We can remodel our spaces to make sure that patients and clinicians can be sitting shoulder to shoulder, looking at the same reality and collaborating to make our work without much distraction or noise. These cards that I'm showing here are being used in a study to give voice to patients who may want to bring up issues related to their experience of care and may need some help doing it. Some of the work that we've done with shared decision-making, and this QR code takes you to our website with some of those freely available tools, help us, clinicians and patients, and sometimes peer patients with peer patients, discuss what might be an appropriate response to the patient's situation at hand. At the end of the day, what we want to do is create programs of care that may not be easy, may not be simple, but are doable in the circumstances and conditions of patients. We want care that fits the lives and loves of our patients. We want to move from a situation where there might be a lot of healthcare, but as we can see in the eyes of Maria Luisa, there may not be a lot of health, to one in which we can recover and regenerate health. Here is Maria Luisa, a fellow Peruvian, enjoying a delicious fish, moving up and down the stairs on an elevator without the fear of falling, and having the time and energy to spend with her loved ones, moving towards health through care. And it is magical that when we allow for care to thrive and flourish, we will see not just the joy of our patients receiving that care, but the joy of the caregiver in the opportunity and privilege of being at the bedside, able and capable of care. And for that, we need a system of healthcare that is based on solidarity and not greed, that is based on integrity and not just regulations, that is based on elegance, no waste, no haste, rather than simply efficiency, that is able to produce care for this patient, not for patients like this, that is minimally disruptive of their lives and loves, and that in itself is not based on interactions, on transactions of business transactions, but is capable of producing enduring relationships akin to love. So perhaps we're painting a picture of something that is hard to get from here. This is the Sagrada Familia in Barcelona, and anybody that has visited would always see those cranes, because this is a church that is always being built, and generation after generation is adding beauty and detail to it. The original architect, the original drawings, the people that put the first rock on the ground are long gone. But yet there is a community that is building this project larger than themselves and continues to do so for generations to come. And perhaps the idea of building an alternative to industrial healthcare is something that will take multiple generations. perhaps it is a hopeful utopia. Hopeful because it doesn't indulge pessimism or optimism. The notion that the world will be either worse or better regardless of what we do, but rather endorses the notion of hope, that the world can be made better by our actions today. And perhaps a utopia in the way that the poet thought of it as a horizon, that we take 5 steps towards and the horizon takes 5 steps back. That the horizon takes 10 steps backwards and we take that step forward and trying to catch it. And when we ask why we need utopias, it is, of course, because they make us walk. They make us walk towards a better reality. In our organization, we're trying to create that reality, help people with the biggest barrier to endorse an alternative future, which is the notion of recognizing that it is possible. And so we're in the process of building a global network of demonstration primary care clinics in which careful and kind care can be made a reality, something that caregivers can offer and any and everyone can enjoy. Because care is what we need to commit as we go through this portal of COVID. As we move forward, we need to become a more caring world. And we have heard about the commitment of Scotland to care for the environment. We also need to care for our communities. We need to renew our care for our patients and for everyone made vulnerable by disease and socioeconomic situation. We need to take care of our caregivers, our health professionals. We need to take care for and about and with each other, because it is with this careful and kind care for all that we will move towards a much, much better future, a much, much kinder and healthier world than the one that we're going through right now. Thank you very much for your attention.
Do you know, Victor, it's about 9 years since I first met you, and you were speaking at a conference in Washington on primary care. And I remember being enthralled the first time I heard you, and it's got no less powerful over the years on the number of occasions I've heard you since then. Thank you so much for providing that absolutely inspirational introduction to our launch today. I'm sure that there are many questions that people want to ask you, but there's a few that I have of my own. And one of the things that was, for me, very striking about what you had to say there was actually some of the imagery that you used, that you painted both with the words that you spoke and that you showed with the some of the images. The image that sticks in my mind is of the two older people embracing. It's wonderful. The experience of so many of our population over the last 12 months has been that physical contact has been something which has been much, much more difficult, something we took for granted in the past, even within our families and those people that we love. And we've not always had that opportunity to be able to express love and care and compassion in the way that we've become used to. And that single image, I think, is more than anything else, is the image that I'm going to take with me today and hold very, very dear to me, because it's something which I think just sums up that compassion and love and kindness that we all want to move back to. So thank you so much for showing that today. I'm going to move on because I've got so much I want to ask you. I mean, it's ages since we had last had a chance to have a proper chat, and you were in Edinburgh maybe a couple of years ago, and we were able to get a bit of a gab at that point, and I missed that opportunity to really ask Victor what's it been like for you. So that's how I'm going to start actually today. Is just, I mean, this experience in the States that we've watched from afar, that you've been closer to. Tell me a little bit about what that last 12 months of being able to provide that careful and kind care has felt like for you.
I've been very, very lucky that I've worked in, I work in Rochester, Minnesota. It's a very small town, 100,000 people. The Mayo Clinic is in it. The Mayo Clinic employs like 60,000 of those people. So it's really a medical town that people come for medical care. So there's a lot of facilities that exceed, of course, the needs of the geographical community. And so we haven't really been overwhelmed by the demands of medical care. But I'm a diabetes doctor, and so many of my patients have gone through hell through this time. They started by hearing that if they have diabetes, they will die of COVID. Then they heard that their outpatient clinicians, the people that are part of their team to take care of them, were not available. Practices were closed, and they were not seeing patients, and they couldn't go in and get the care they needed. And so they were threatened with an adverse outcome and then abandoned by most of the health services. And so they were left to their own devices, and some of them had to take off time from work or became isolated from their caregivers, their family caregivers. And for some, it's been a great opportunity to have time and control of their environment to institute better self-care. And for others, it's been absolutely devastating because the stress, which in the United States was compounded by political stress, by social violence, by violence of all sorts of with different colors, orange included, were extremely hard for people to take on. And so I have patients who have done phenomenally well when taken off work, when having time to reflect on things and take care of themselves, and people who have struggled mightily. And as we learn to get closer to people through technology and other approaches, as we were able to reconnect again, it's been a wonderful opportunity to help folks. And of course, now with the vaccine being distributed to many of my patients and to myself, the opportunity for touch, for connection, for physical connection, goes up. Personally, there's 5 in my family. I'm vaccinated. 3 of my family members have got COVID. And the only one that is not vaccinated yet and hasn't had COVID is my son who lives with immunosuppression. So, we still had a healthy degree of anxiety related to that, but we've done, despite having had the virus in our midst, we've done better than most. And we're, of course, walking away from this incredibly grateful just enormously grateful for the opportunity to have another shot at making a difference in the world.
There's the 2 elements there I want to come back on, Victor, because I think they're really important aspects of the compassionate care that we've become used to providing patients, and that's the aspects of physical touch, but also expression. And when you're wearing a mask and trying to communicate with someone, it's sometimes very difficult to kind of really capture some of the essence of communication and compassion that we want to be able to express in that relationship. And I sometimes in the past have told the story of a lady who used to come to see me as a GP, and she used to come down every 4 weeks without fail, and she used to wander down to the practice and take her seat and have a little bit of a chat with other people in the practice, and before she came through to see me to speak to me about the osteoarthritis she had in her knee. Now, her knee never changed from 1 month to the next, but the stories she told me changed. And what she was looking for was that sense of connection with people in the practice. And we would have a little bit of a chat for 10 minutes or so. I would lay my hand on her knee just to check it again, and I would maybe check her pulse or her blood pressure. And there would be that element of physical connection. We'd speak about various things that were going on in her life, and then she would leave quite happy because her treatment didn't change, but she'd had that social connection that we crave. And it was a really important aspect of her life was that she had that opportunity to be able to do that. And care has changed as a consequence of the way that we must provide safe care just now. And I often wonder, so many people within our society who use that sense of connection with their caregivers in some way to provide some sort of sustenance, how they've impacted. What you've described there with your patients was fear and anxiety and some sense of displacement at times. So how have you worked to promote that sense of agency for those people? You mentioned technology as an enabler. Can you say a little bit more about that?
Well, so I will, but let me go back to your initial comment. I think that that for many in healthcare, this notion that somebody will have to go and see their clinician to have social connection and to be able to get care is preposterous. You are an extremely expensive resource. Your time is very precious. There are other people who have actual medical needs that need you, and yet you're spending time with this person who, as you said, has a need that hasn't really changed. And some people find that extremely low value use for healthcare. And of course, I hope that people are picking up that I'm not endorsing any of those ideas. But I think we need to think about exactly why that happens. And I am convinced that there is an opportunity to take care, which has been the central theme of my presentation, to take care and make sure that we look at the way we are conducting ourselves, not professionally, in our communities, and think about how can we bring more care into our communities. I think many people in your position, Gregor, I think are thinking of how do we bring health in every policy, right? How do we promote health with every policy? But there's also an opportunity, I think, to say, how do we promote care and caring in every policy, in everything that we do in our community? How do we ensure that people have the time to care for themselves, to take care for their loved ones? As you know, care has been something that over the years have been very gendered. And with further development, it's been something that has been delegated not only to women, but also to often immigrants, women of color, and people with low socioeconomic status. Something that is done in the background, in the privacy of someone's home or out of sight. And this lack of recognition, this lack of reward of care, and this gendered approach to care needs to fundamentally change. So I'm using the opportunity of this manual to actually make the case that I think it is an important agenda to try to move care away from this idea of a gendered activity that occurs in the background to something that we do and characterizes our humanity, characterizes the health of our communities, how caring our communities, how do we care for each other, how do we care for those in need of more care? How do we develop the skills for, I mean, we are training people to resuscitate dead people in the streets by using, CPR. But if somebody starts crying on the table next door at a restaurant, we might want to look away. And so we need to be able to, care for our children, care for, how do you safely bathe an elderly person living in your house, right? We should have not just cooking shows, but caring shows so that we learn those skills and rely less on the healthcare system, not to make the healthcare system less busy or to reduce costs, but because we have developed a better world when we care for each other, when we care for our communities, and we care for our environment. So that is, I think, an important part. You asked about technology. And I think technology, first of all, technology is making this conversation possible, right? And in part, it's making this conversation possible because we have the resources to do it. So we have to be very careful that as we rely on technology, that we do not leave people out who simply cannot make it work. I'm reminded of the movie Daniel Blake, in which this gentleman goes trying to secure resources, and the officer tells him, "Well, we are digital by default." And Daniel Blake responds, "Yes, but I'm pencil by default." And at Mayo Clinic, one of the most common phrases I've heard at the desk when people are approaching the desk is the word flip phone. It's like, why are people talking about flip phones? And it's because all these people are being told, would you be interested in a video call? And do you have access to your medical record through your smartphone? And they're answering, I just have a flip phone. So we have to recognize that while technology offers massive opportunity, we remain in a situation where there's a huge diversity of access to that technology and literacy, digital literacy to use it. So yes, technology has brought to my practice people that I would never have seen before, even before the pandemic. So it's not just the contact with my patients that I lost during the pandemic, but even people that would not have accessed me before the pandemic. Now we're able to bridge the geographic gap, just like your Near Me program, through technology. And I'm very grateful for that. But again, we have to remind ourselves that other people who need us to go to them. And sometimes the best technology that we will have for that is our 2 feet.
As you were speaking there, you won't recognise this reference that I'm going to make, Victor, but other people who are watching us might. I'm imagining a Saturday morning show with James Martin, one of the UK's favourite TV chefs, and rather than Saturday morning kitchen, it'd been Saturday morning bathroom. It's perhaps not got the ratings pool that his current show would have, but you make an important point, because we support people to learn how to do things like that, and we will get the results that we reap from how much support that we provide. I was struck earlier on in comments that Jerry and Diane were making about the inequalities that exist across Scotland, and for many years Scotland has had a real challenge as we try to kind of surmount some of those inequalities. And I think your point about making sure that we don't actually make those inequalities worse through unfair use of digital technology is something which has been very much at the forefront of our mind. So the approach that NHS Near Me has taken, I absolutely commend, in trying to make that as accessible and widely available as possible. And I want to pick up, there's probably some of the, on this webinar just now, there's probably some third sector organisations, I hope, who are maybe listening to us. And within the third sector in Scotland, we've got an incredibly active community of organisations who assist what has been traditional health services in terms of providing that, for want of a better term, direct care or frontline care. Is that something which you have a lot of experience with in the Mayo Clinic, or do you tend to find that it's a different relationship with some of those voluntary and charitable organisations?
Yeah, to help patients live with chronic conditions, again, my area of clinical activity, it is often necessary to make the warm handoffs to organizations in the community that can assist them with getting the resources they need to be able to be successful at that, in relation to food security, housing security, the transportation, and so forth. It's interesting, the comment I would make about that is that, those organizations have been essential for many of our patients, and that is a problem. And it's a problem in the following way. If every need is covered either by a governmental agency or by a nonprofit organization, if the form of care is always professionalized or institutionalized, or if I may, the term is not right, but if it's privatized in the sense that it's actually made the purview of an entity that is outside of us being the community, then the community gets two messages. One is it is not my responsibility to care for my own. And the second message is that I don't have to notice those things anymore because it is someone's job. So if we want a more caring world, we need to notice and respond. We need to be attentive to the needs of others, and we need to feel responsible for their lot in the world. And to delegate all those responses, I can understand delegating the most complex and the most technically difficult, but to delegate all of those responses to other entities outside the community, this empowers the community, this skills the community, and makes the community less caring. And I had an interesting personal experience. I was I'm from Peru originally. I spent 2 years in Canada, and I was flying back from visiting my family in Peru, flying back to Canada. When I arrived, I can't remember the exact year, it might have been 2003, there was a blackout. The power grid failed in the northeast of North America, so affect New York and that area in the United States, and affected Toronto and Hamilton and Ontario and in Canada. And I was in Hamilton, so we landed there. We got to our townhouse where we were living with my family, and there was no electricity, and so we walked down from our house to a corner shop where there were some sandwiches and water, and we sat down to eat, because there was nothing in our fridge, and there was no light. And while we were there was an extraordinary reaction that this place became the hub. So people from that neighborhood got together and start going down the list. Where's Mrs. Jones? She lives in the 3rd floor. There's no elevator. Can somebody go and check on her? And they start, this basically like a rescue brigade on the spot, thinking about who may not be able to, noticing who may have a need, and feeling responsible and acting on that responsibility to care for each other. But well, we'll have the fire department take care of them. We'll have somebody else covered. But they didn't wait for anyone else. They noticed and responded. I like to live in that town. That makes my life better. And that's without being sick. But if I'm sick and I know that the people around me are a potential source of a way out of my situation, or a better adaptations that make my life easier, that's a better town, that's a better community, that's a better country to live in. So I think that's another aspect of this that I think is worth discussing.
I remember attending a seminar with Salzburg Global. Salzburg Global were hosting a seminar looking at palliative care. This is many years ago.
I never get invited to those places. Oh, yeah.
And there was countries from all over the world there, Victor, and many of the countries came from sub-Saharan Africa. And whilst people relayed their experience of providing palliative care, and many of the Western countries spoke about the increasing technicality or technical approach that they were taking to palliative care and how they delivered it, some of the most moving and some of the most rewarding experiences that I brought back from that was actually the experience of some of the care that was provided in countries like Malawi and Rwanda, where collectively communities came together when someone became sick to help to provide and support families to provide the care that they wanted to give. And I've often thought that actually Western society's got an awful lot to learn from some of these communities about how we share that experience and promote that collectivism and community response when people are ill as well. But perhaps that's for another time. You and I can develop that.
Yeah, except that, Gregor, I think we've seen in early COVID, we've seen communities in our countries, not necessarily in other more perhaps in different situations, but in our own countries, we've seen people honor care, go out and clap for our healthcare professionals, care for each other, go sing to people, from the roof across the street, sing to the nursing home patients, or play bingo with them. We've seen that we have the ability, we have the intuition of noticing and responding and honoring care. But there's something in our software that then takes us into this more of a selfish, less caring mindset. And I think that's the task ahead, is how do we bring care into healthcare, but also how do we bring care into our communities? I think you and I have both seen it with our own eyes. It is possible. It is possible now. It is possible in our communities. We don't have to go to Malawi to see that.
So preserving that, consolidating it, and making sure it just becomes the norm becomes really, really important. I'm going to move the conversation on just a little bit, because one of the people that we heard speak earlier on, and I don't know whether Cameron even realises this at all, he probably doesn't, but Cameron's dad was actually responsible for teaching me much about medicine. He was my trainer when I became a GP, so that may be a bit of a revelation to Cameron today. But one of the things that was really important within that practice, and that his dad Murray taught me, was that the looking out for each other within a team. the supporting each other. There was always protected time within that practice where people came together. And we might have been signing prescriptions, we might have been updating records, we might have been going over letters, but we ate together, we had coffee together, we shared stories together. And when we needed support, there was that ear who was ready to listen to us. And I always thought that that was incredibly important. What would you say the experience of your colleagues was in the States just now, and how have Mayo gone about trying to promote that type of environment where people have experienced that support and enable teams to work in a high functioning way?
So this is a difficult question for me because I don't have a positive view of what we've done to care for each other in the healthcare system. Where in the context in which I work, there's been a big push for two things. One, efficiency, and the other one is compliance with safety regulations. And they've been put above almost everything else. So a couple of things that have occurred is when I joined Mayo as a group practice, when I joined the group practice and you came to a floor where you work with your colleagues, this is the building in which I work has 19 floors of clinical practice. So I worked in the 18th floor. And so when you walk in, there will be a light system. So anybody that walked in flipped a light and you could see who was on the floor. There was a system in place from the first day where you could, we're talking about the 1910s, 20s, where you could actually have a flag outside the doors of the people that were inside. So you can just look down a corridor and you could tell who of your colleagues was in. And so you could just go in and chat with them and so forth. When we remodeled for efficiency, we removed those signs. So you walked into a floor, you didn't know who is in, and you could not tell who was in the room. So if you had to go and talk to someone, you have to kind of open every door and then look for your colleague, which of course you end up learning very quickly not to do, because A, you're going to interrupt somebody, and B, you may not find anybody after a while, and it's a waste of your time. So that's part one. Part two is there used to be a coffee machine that was right behind the desk. So if you look at the disposition, pretty much as you finish with every patient, you would sort of walk by it on the way to the next patient. And so it became a hub. And so if you tracked people moving around, you could see the professionals will be bumping into each other at the coffee machine. And I remember some of the better conversations about, I just saw a difficult patient, or the other person who's telling me about a difficult case, or some of the old guys will be telling me about how it used to be in the old days. And so I realized I was part of something bigger. So there was a culture of communication and enjoyment and gathering and camaraderie and laying eyes on each other, so that if we know that somebody's struggling, we could reach out and help them out. The coffee machine was considered food in a patient care area, and it was removed and taken out into a break room, which of course was out of the way. And one of the unintended consequences of that is that we stop seeing each other. And so now we have colleagues that we learn later have been in trouble emotionally and having difficulty that we just didn't see. We didn't see it coming. We didn't see it when it was happening. We were not there for them to offer a hand and see how we might help. And I don't know that we fully realize when we've done those changes, what is the unintended consequence of some of the changes we do for efficiency or safety that they have on the issues of camaraderie and mutual support and mutual care that I think set us up to be emotionally and cognitively present when we need to take care of the next patient.
I think that's a fascinating point, isn't it? Is the tension that exists between some of these aims that we create with the best of intentions within the system, but sometimes have those unintended consequences. And it's the universal language of caffeine, isn't it? Without caffeine, how would we function as healthcare professionals? Before we start to wind up, I am, as I say, eternally grateful for the time you've given us today, Victor. I really am. Tell us a little bit, please, just to wind up, why is delivering careful and kind care more important now than ever?
I think it's always been critical, but I don't know that it's been always available. I don't know that the possibility has always been within reach. Some people catch, and I've used this in my own language, thinking about how do we bring care back into healthcare, and it's not bringing it back. I think we can all go back and think of situations where healthcare has been cruel to people and has not been that caring. So it's not about bringing care back. It's enhancing or adding care where we have not been able to implement it, or we've lost some possibilities of care because of the things we've been discussing. And I think this is within reach because we have more to, so we have better ways of noticing when people are in trouble. We have better diagnostics and technology and other things that may actually allow us for more possibility of paying attention with our own senses and to listen to people better, because we have technologies and systems that could allow us to be more efficient in other aspects of our work. We have more ways of responding. Again, we have new treatments, new technologies that allow us to respond, but also leave room for that time and that attention and that laying of the hands and other things that are important in our human communication of regard and care and looking after, that is important for care. So we can do better care and we can do more careful care because we have more technology and we have a better recognition now than I think we have ever before about the importance of those personal offerings that a caregiver can give to a care receiver to actually advance their situation with compassion and competence. And then the other aspect is that these technologies and these systems allow us now to be very elegant, no haste and no waste in doing that, where in the past we may not have had that opportunity because we just didn't have the wherewithal to do it. So we have a renewed commitment. We have the technologies and ability to do it. More and more health professionals are being trained in issues of compassion and empathy and the narrative medicine and all these other things that allow you to do a better job. We're still, however, bringing them into hospitals and clinics where we put in front of them role models that operate under efficiency. They're operating under massive egos. They're operating under a significant amount of cruelty. And those students are learning that in order to fit in, they have to behave in those ways. And so we still have things to do, but we're closer than ever to actually, I think a real revolution of care is within reach. And as we stop being so enamored with the artificial intelligence and the new systems and the robotics and all this sort of thing, yeah, they're great tools. But boy, our inherent ability to look after people, to care for and about each other, to care with each other, is something that is an inherently human thing. And we have in our hands the possibility of making that the way we do things every day, not just in the professional space, but also in the public and personal spaces. What a wonderful thing to take away from one of the darkest periods of our history, of our modern history. What a wonderful thing to get through that portal that Arundhati Roy talks about is COVID. You choose what you're going to bring with you through that portal. Well, what did we bring? This enormous richness of our ability to care. Wow, if we can make that world more caring versus this careless one that we have now, wow, wouldn't that be the best gift we can give to our children and our children's children?
I was going to ask you another question, but I don't think there's a more perfect way that we could end this little chat on. Victor, thank you. Thank you for giving us your time, for sharing your wisdom with us. But more than anything, thank you for being that role model that you spoke about, who can provide us with a different perspective on actually what makes someone who provides high quality care really tick, and that all of us involved in this call can aspire to trying to do our bit to achieve as well. So Victor, thank you very much, and I hope we get the chance to catch up again soon. Savita, back over to you.
Thank you both for your insights and reflections. A potential format for a chat show there, I think. Victor, to echo Gregor, again, thank you so much for your time, for your incredibly inspirational talk, which appears to have even moved some of our audience members to tears. So that brings us to the end of our session. A few thank yous now. A huge thank you to Gregor, Amanda, Jerry, Cameron, Diane, and Emma, as well as for our multiple contributors to the annual report. Thank you to the Realistic Medicine Policy Team led by Craig Bell. Gail, Carol, and Finlay at NES, thank you for all your technical support, and a very special thank you to Jennifer Graham for all her hard work organizing this wonderful launch event.
So we hope that the report will provide some space to reflect on the past year, recognise issues that require urgent attention, and support us to recover, restore, renew our health and care services for the people of Scotland. Thank you all for participating in this live launch event, and remember to keep the conversation going on Twitter. Thanks again.
Before we all leave, one last word of thanks to Savita and to Julie for everything that you have accomplished during your clinical leadership year, and for what for me is a report that I'm incredibly proud of. Thank you for all the work and the effort that you've put in collating this wonderful material, for helping to guide the authors who've been involved in this. It's an immensely proud day for me, and I'm very grateful to both of you for everything that you've done to help me. Thank you.